Good day, everyone. My name is Jay Williams, CMO of Southland MD, the continuing the trauma series along with Hometown Health. Today, we're going to discuss the golden hour. So let's get started. Full disclosures, financial disclosures. We and myself have no proprietary interest or ownership in the information provided here. We don't get paid for this presentation or for any use of any of the supplies or medicines we will discuss. I will also try to keep medication names generic. If I pronounce them out of trade name, it's probably because nobody can pronounce them, including myself. So looking forward to getting going here. So nothing to disclose. A little bit about myself. My name is Jay Williams. I've been practicing in the rural community settings as well as level 1 trauma centers since 2005. I graduated from University of Florida in Jacksonville. Been working in rural Georgia pretty much ever since 2008. Very familiar with the facilities and communities that each of you serve. Appreciate the passion, the dedication that each of you provide to the communities you serve, and it doesn't go unnoticed. So appreciate you being out there. So let's get going. So objectives today, after learning this course, we're going to focus on what is the golden hour, identify the latest ATLS updates, including those specifically on the golden hour care, identify what resources are needed, identify the hemorrhage control algorithm, and identify the elements of the MARCH protocol. Within this topic, I would like to spend a few minutes discussing what I think are mandatory must-haves in your facility, no matter the size. This presentation, as well as most of our trauma presentations of this series, are really tailored to the rural and community emergency departments. That's the vast majority of the emergency departments out there. Far exceed those with trauma designation or high-level resources, including multi-specialist and multi-specialty care centers. So let's get going. What's the golden hour? So the golden hour is critical. It talks about the first 60 minutes after a traumatic injury, includes rapid assessment, definitive therapy. This starts from when the injury occurs. So that includes both EMS setting. It emphasizes life-threatening injuries, especially hemorrhage control, airway compromise, and traumatic brain injury, and decreasing the morbidity and mortality thereof. Delays in care we know can significantly increase this. So early interventions to both decrease our mortality initially and decrease the morbidity that happens there afterwards. Then also transporting those patients to definitive care. If you remember, trauma patients can be brought into any emergency department, both large and small, so we need to be prepared. They also remember that sometimes they don't always come by EMS. We don't always get a report. Sometimes they walk in the front door of your emergency department. So where did this all come from? So the origin of the golden hour. The golden hour really started by a physician named Dr. R. Adams Cowley. He was in Maryland. He believed that survival is highest when definitive care is initiated within that first hour. His work led to the modern trauma systems and trauma centers that we see today. And it really started in the 70s and 80s to get regionalized trauma care and modern EMS structure. It's really not so much a stopwatch. It is having that urgency and making sure we deliver the best care timely and appropriately. So golden hour principles. First 60 minutes are critical. Hemorrhage and hypoxia, they kill people early. Speed over completeness. Remember, this starts when the injury occurs, not when they actually get to professional help. This has led to some really positive changes in our communities as we focus on how can we get out in the community and help people faster. Certain things like Stop the Bleed campaigns, which are tourniquets, similar to CPR training in the community. Anybody can do these simple techniques. How can we get out there and show them how to do that? How can we make tourniquets and AEDs more readily accessible in our communities? So ATLS updates. The most recent ATLS changes, again, this is the 11th edition now currently of ATLS. The emphasis on early hemorrhage control and damage control resuscitation, blood over crystalloid for hemorrhagic shock. Of course, we're losing the red stuff. Let's not replace it with clear stuff. So giving blood early TXA. TXA is a very inexpensive, easy to give, easy to dose medication. Giving that in the appropriate patients, sometimes even pre-hospital. Permissive hypotension, especially in certain things like traumatic brain injury. Pelvic binders, tourniquets, putting those things earlier in the primary survey. Greater focus on rapidly getting these people out of the small facilities that can't manage or don't have the capacity, and also the ultrasound fast as an adjunct to our tools. Modern ATLS aligns with the golden hour. How can we get things done fast, control the bleeding, and to get that patient definitive care? Many things you might have noticed over the years in ATLS are come and gone. Pelvis x-rays went away, now they're back. the ABGs, lactic acids, how much blood to give, how much fluid to give, when do we go to blood. I think you'll find that most of the fluid resuscitation now is focused more on lactated ringers. Lactated ringers also known to be a little bit better maybe in sepsis. So maybe all of us need to rethink our go-to IV fluid resuscitation from normal saline to lactated ringers. The only caveat that I find with LR, sometimes it doesn't mix as well with all our medications, so it's something to think about. The thinners, oh geez, remember when we first started doing this 20 years ago, we started saying, do you take aspirin? Do you take Plavix? Do you take Coumadin? Now we have to say, do you take all these other medications? Some of them we can't even pronounce. So primary survey, secondary survey, how do we get these people out? Airway. So what? We're not talking about intubation, ABCs. Holy cow. Know that the intubation may not be the first tool that you need. I strongly recommend that you get adjunctive airway devices. Sometimes in our community settings, there may be one physician, there may not be a respiratory therapist, there may only be 2 nurses, there may be less. iGel, in my opinion, is a go-to device. I would strongly recommend considering it. Intubation's kind of moved a little bit later, as long as we're oxygenating and securing an airway, protecting further risk of injury, including C-spine, we can always come back to it. I think the iGel is way better than the King tubes or the Combi tubes or the other esophageal devices that I grew up with. I always had to figure which balloon to inflate to get the darn thing to work. So iGel, it's fantastic, it's rapid, it's super glottic. You just put that sucker down, it does a great job of ventilation. You can also do adjuncts. I like bougies, like oral airways, nasopharyngeal airways, having a video laryngoscopy, glide scope, or something similar. I think it's a great tool, but the iGel LMA is fantastic, especially for difficult, complicated, traumatic airways. Oxygenation beats airway. Oxygenation beats intubation. Use the airway that you can get to work right now. For the iGel, I find a little bit of forward pressure on the jaw, just like when you're putting orogastric tubes in, really goes a long way. This is a great tool to have in your basket. I would definitely have it in every emergency department. Fast exam. Oh geez, man, I didn't grow up during ultrasound. How can I do this? This is super simple, super easy. Lots of grant money out there to get an ultrasound that has quality, ability. Nowadays, even some of these ultrasounds have AI capacity. So it's really a great opportunity, something you should have in your tool bag. So focused assessment for sonographic for trauma. It's quick, it's bedside, it checks for internal bleeding. Fantastic for blunt trauma. The car accidents, falls, assaults, what does it look for? It looks for free blood, free fluid in the abdomen. You can also look for blood around the heart. You've also might have heard in EFAST. Oh geez, now we're making it complicated. Looking for pneumothorax, hemothorax. You can do this in just a few minutes. It helps us decide when does a patient need to be transferred out right away. It also is a test we can easily repeat. That patient gets worse, we can easily reassess and see what's going on. So here's a simple look. This is Morrison's pouch. This is the right upper quadrant. This is normally the first place you do for fast. This is where you're going to see blood first. Normal fast on the left-hand side here, no fluid. Abnormal fast, you're going to see this blood or fluid between the liver and the kidney. The fast guides decisions, helps you not delay care. Positive fast, time to do something. This patient may need the operating room right away. The 4 typical areas that we do fast exams: cardiac, suprapubic around the bladder, splenorenal splice. I find that sometimes a little bit challenging. Just take your hand, put it on the back of the bed, and then look north, and you'll usually find it right away. The 5th and 6th area is the lungs. If you get really good, you can see the lungs, they'll slide back and forth. Shows you that there's no pneumothorax. They can even show you little subtle pneumothoraxes that you might not see on a portable chest x-ray. If you get really good, you can also look at the optic nerve, check for intracranial pressure. It might be a patient that can go to the operating room before they need that critical head CT if you're in a definitive care setting. So code trauma. Let's get prepared, guys. Just like we have code stroke, code sepsis, the code trauma is something all of our facilities should have. The activated code trauma, get everybody to CM roles. Give everybody a role so they know what they're going to do ahead of time. Be ready. How does that look? Do we call people on the phone? Do we page it overhead? Let's be ready. Let's give everybody a task so that when the patient gets there and we know they're coming, we're ready to go. Let's also practice in case that patient comes in the front door. The rapid primary survey, airway, C-spine precautions, that's what we talked about earlier. Make sure that breathing's okay. Check for circulation, disability, exposure. Let's warm the patient up if they're cold. Let's also make sure we don't have something that needs to be decon. Let's protect our patients. Let's protect our staff. So if something needs to be run through decon quickly while we protect our C-spine, let's get that done right away. Hemorrhage control. Everybody can do this. Direct pressure, tourniquets, pelvic binders. Get a couple IVs. Do we need mass transfusion protocol? Rapid diagnostics, we talked about portable x-ray, portable pelvis x-rays. Do we have point of care labs that might help us? Fast exam. These CT scans only meant if they're stable. Critical decisions. Does a patient need to go to the CAT scan? They need to go to the OR. They need to go to interventional radiology. Just like you're finding in the medical world, interventional radiology, similar to caths, is a way to stop bleeding, safer for the patient, less surgicals, better outcomes. So similarly, you're finding cardiac cath versus open heart surgery. Do they need to go to the ER? Do we need to transfer them? Time-based documentation. Let's make sure somebody's putting the time they came in, what time we're doing critical interventions. Somebody should act as the recorder so we can move forward right away. This is also very important, a team debrief. I think really looking back saying, how could we have done things better? How could we have done things faster? How could we have been better for our patients? And even how can we be better for our staff? Some of these trauma cases that come in are people that we know, especially in the community setting. How can we debrief and make sure our staff understands they did a good job? How can we get better? But they did a good job. We're prepared and we're ready to go. Every hospital needs a code trauma. So March protocols. A little bit about March protocols. There it is again. Airway is now second. So massive hemorrhage control, airway, respiration, circulation, hypothermia, head injury. Wow, March protocol. This is something we're really going to explore in our next series. So more to come on this later, but I want to at least kind of talk about it very briefly. Fluid resuscitation. So Easy IO, another tool that I think everybody should have in their tool bag. Easy IO is so much easier, so much faster than the old IOs. For those of you that used to kind of really work those to get those going, proximal tibia was kind of where we always taught ourselves. A little bit below the knee. It was pretty simple to do. But now there's better ways. Look at this humerus IO. If you've ever seen or put in a humerus IO, this is the way to go. The IOs can be placed in a matter of seconds. You can put lots of IV fluids, lots of blood products right in the humeral IO. Flush them regrettably, confirm placement. I tell everybody, lose your ego. We all like central lines. We all like to put in IVs, but easy IOs are fast. They're awesome. Once you put it in the humerus, you'll never do anything else in a really critical patient. If you need volume, choose the humerus in an adult. Humeral versus tibia IO. We talked about that a little bit better. You can do a lot more fluids in a humerus than you can in the tibia. It's closer to the central circulation, so we think and we know that it gets there faster. I would strongly encourage you to go to the Easy IO or some vendor type website. You can see the videos. It is really great. It is really awesome. If you ever get the opportunity to do it in the cadaver lab, it'll show you exactly. It's a preferred site for massive transfusion and shock resuscitation. It's a thinner cortical bone, so it's a little easier to get it in. You'll also find that there's less resistance to put it in. It's less likely to come out, and it's more likely to be successful in the first attempt. So humerus is definitely the way to go versus tibia. We could talk about the volumes next. So look at the amount of volumes you can put in. For the humerus, you're easily able to put in 50% more volume. That's just with gravity. You put a pressure bag in, you can get 9 liters of fluid or blood in a humeral IO versus about 6 in a tibia. Still pretty good. The only thing I'll tell you about a humeral IO is if you're doing CPR compressions, especially in the Lucas type device where the patient's arms are up, make sure someone secured that humeral IO because it's easy to move out of the way. But still, even with those duress or those critical patients, the humerus has been shown to displace markedly less than the tibia. So if you need volume, you need blood, let's go humeral IO. In kids, proximal tibia is still probably the most common. I would say that the distal femur is an excellent alternative, especially for the toddlers and younger infants. Very similar to the humeral IO. It's less likely to be displaced, less likely to be dislodged, and more likely to have a first attempt that is successful. So distal femur is definitely something you should practice, definitely something you should teach your EMS colleagues. Humeral IO, once we get to older adolescents where the landmarks are a little more easily identified, definitely an option as well. Crystalloid versus blood. Okay, we talked a little bit about fluids. We talked about we're losing red stuff. Why are we putting clear stuff back in? So limit your IV fluid resuscitation to about maybe half a liter, maybe a liter. We should be giving blood right away. Activate your mass transfusion protocol right away. What does that look like in your setting? Sometimes that's just a lab guy with a warm water or fluids really trying to get that blood or that plasma ready. Sometimes it's really specialized equipment. Whole blood, man, that's the way to go. Can you even get it in your facility? So establishing that IV and IO, get a large gauge, get that blood warm, and let's start giving the red stuff versus the clear stuff. Let's give it right away. Let's give it early. So rapid blood transfuser. There's a lot of these on the market these days. Again, we talked about activate your mass transfusion protocol right away. That may look different in your setting. The prioritize blood over crystalloids, especially use 1-to-1-to-1. Packed red blood cells, plasma, platelets. I understand that many community and rural hospitals don't even have platelets. Some of them have a very limited access to packed red blood cells or even plasma. Most of us have a couple units of PRVCs going around. We can at least start that while we're getting that patient ready for transfer to definitive therapy. Warm the blood products anytime you can. We really don't want to get hypothermia if that makes them worse. We talked about large volume, large bore IV, easy IO. It's the way to go. It's the way to do this. So blood delivery, it matters as much as blood selection. There's different types of blood type. We can go into that at a later setting. O negative, O positive, most of the time okay, especially in older adults. But we'll go over that in detail at a later date. So pressure bags, those are simple. It can be your mass transfusion protocol. It can be somebody warming up, thawing the blood. Pressure bag, widely available, very effective. You can use a blood pressure cuff, cheap, easy way. Pump that sucker up, get it going. There's also rapid infusers, level ones or Belmonts are the classic brand names of these. There are several others on the market. High flow, they've warmed up. You can get blood in a hurry. Sometimes they're expensive. Sometimes we don't use them that often. We don't really know how to use them very well. So I would recommend at least once a year, maybe twice a year, work on your mass transfusion protocol. Do a trial of it. Let's make sure everybody knows what their role will be when that happens, especially if you've got a Belmont or a level one, some sophisticated machinery. If you don't know how to use it, or if you have a new nurse or a nurse that hasn't been in your setting, let's at least make sure we know how to use those things. Syringe push versus stopcock. The syringe push, easy to do. Then we talked about reducing hypothermia, so make sure we're giving warm blood any chance we get. So again, give it early, give it fast. This saves lives. TXA. TXA has been around for a long time. It's originally a very popular drug for gynecological bleeding. It's now something to be used in trauma all the time. I would strongly recommend to your EMS colleagues that this is something we should be giving early, especially if we're worried. The typical dose is a gram over 10 minutes, then give another gram over 8 hours. I can tell you that 15 mg per kg is an easy dose to give everybody. Just 1 gram is what the vial comes in, so it comes very simple to do that. You should give this early. Give it within 3 hours. There's a couple studies that say, yeah, maybe we can give it a little longer, but the data definitely supports giving this early, definitely within the first few hours of any traumatic injury. You can give it in abdominal pathology, shock patient, brain injury. There's really very limited side effect profiles or very limited negative outcomes you can do by giving TXA. Similar in peds, 15 mg per kg. Give that early. Max is the adult dose, as we know with most kids. So it's a time-dependent intervention. Definitely been shown to help in the first 3 hours. Give it early. Late dosing probably doesn't help as much. Pediatrics mirrors the adults up to a max dose. Hemorrhage control. Golden hour. Life-threatening bleed, find it, stop it. Tourniquet, direct pressures, putting an IO in, giving blood, giving TXA, early transfer to a trauma center. This is really what the golden hour hemorrhagic control algorithm is. Stop the bleed. There should be tourniquets in everybody's waiting room. So if a patient comes in by car, we can deliver that tourniquet right away. All of your EMS colleagues should have a tourniquet. They know how to use them. They're cheap. You can get them free with grant support now. There's no reason not to have a tourniquet in your facility. Tourniquets, life-threatening extremity hemorrhage. Apply them high and tight. Get that sucker under control. Tighten until the bleeding stops and you don't have a distal pulse. Sometimes they're uncomfortable. You have to give patients pain control, but this can save lives. Give it early. We oftentimes should be teaching first responders how to do this in the communities, just like we should be doing with AEDs. Secure the device. Usually put a time on it. I don't think that's that important. We'll talk about that as well. Don't loosen it. Don't intermittently release it. Leave it on. Let it do its job and get that bleeding stopped. You can leave a tourniquet in place for several hours. You don't have to worry about taking them off right away. Pediatric note, same thing. You can use a tourniquet in kids just like you can in adults. The things I find that people have the most trouble with is they'll put it too distally. They won't tighten it enough, or sometimes they won't document the time for transfer so that somebody knows how long they've been on. Again, don't let that be your rate limiting step. These can stay on for quite some time. This saves lives. The bleeding is going to kill much faster than a limb ischemia. So please, please put that tourniquet on, leave it on. There's no reason to take it off. If you come in with EMS and have a tourniquet on and you have an isolated extremity trauma, if you want to take that tourniquet down, be ready to prepare something. Be ready to repair. Have your laceration kit. Have your lidocaine, especially with maybe epinephrine. So that way you're really able to get hemostasis. But it's okay. If you're not really sure and you got a bad injury, it's okay to leave that tourniquet on until they get to the next definitive care. The most important thing, stop the bleeding. We can repair it later. We can fix any pathology later that's needed to be fixed. Transfer. All right, big deal. Airway secured or oxygenation adequate. We talked about it. Sometimes this isn't a patient that actually has to be intubated. Sometimes this is a patient that just needs oxygenation. So you're protecting their airway, protecting that C-spine, delivering oxygen. Their oxygen saturations are good. Get that bleeding control. Start the bleeding if they need it. Go ahead and give that right up front. If you see a patient bleeding massively, it's time to go ahead and start a blood transfusion. You should not be waiting on a CBC or results to come back to give that. We all know hours later that's going to be markedly less. Vitals reassessed. Keep an eye on those vital signs. It's okay to keep them borderline blood pressure. You don't have to keep them very high. Do that fast. You can do the fast again if you need to, and get that patient transfer initiated early. Most of the times, most of the settings, most of your helicopter partners will want you to call them early. They will come right away. They will be an extra set of hands, sometimes the most experienced hand with trauma. So call them early, activate them so they can get to your hospital and get you some help. So stabilize for transport, not for diagnosis. Do not delay transfer for a CAT scan. The worst place to do a cardiac arrest or a code is in the CT scanner. There is not a surgeon in that CAT scanner that's going to help you. So do not delay transfer for a CT scan, especially if the patient's unstable. If a patient comes to the rural emergency department or the community emergency department and you do a chest x-ray and a pelvis, you do a binder, you oxygenate them, you stop the bleeding, and you transfer them out within 30 minutes, you have saved a life. Nothing you did in the CAT scanner saved that patient's life. So don't wait on labs. Don't wait on the CAT scan. Consult who you need to consult. Get the vital signs a little better and stable. Start giving blood early and get that patient transferred. Again, there's no worse place to run a cardiac arrest than in the CAT scanner. If the patient's stable, you might decide you want to do a CAT scan to decide which trauma center the patient might need. But if they're unstable, forget about it. Let's get that patient out of there and let's get the patient where they can get definitive care. Decontamination. We talked about this a little earlier. Let's protect our staff. Sometimes bringing a critical patient into the emergency department with all of our staff is not the best idea either. So consider decontamination for chemical, biological, or radiological warfare. They know that in our small communities, especially with agricultural potential, these things can happen in your communities. They are not always things that happen in big chemical plants in large urban settings. Unknown powder, liquid, industrial accidents, hazardous material scenes. So make sure that you're coordinating with the EMS, fire, and the hospital leadership to say, do we have the stuff we need for decon that we can do fast? Does this patient need to be seen outside versus inside? How can we keep our staff safe? Keep the patient safe and make sure that we don't have a bad outcome. So work with your EMS partners. We should be thinking about decon for any critical situation. We may need to take a second, clarify the room needed, clarify what we need before we move to our typical trauma pathway. Needs. What every rural and community hospital must have. I think there's several things that we just have to have. I think it's very important. Airway essentials. Of course, we need oxygen. Of course, we need bag valve masks. We need these for multiple different airway types: pediatric, infants, adults. Supraglottic airway. We talked about the IGL. It's probably my favorite. I would also have several other adjuncts. There's plenty out there. You can even keep those old esophageal devices if you had them around. They still work fine, but I think for the novice user, something like an IGL is very simple. Intubation backup. Who might that be? That might be the paramedic that brought him in. That might be a respiratory therapist. Again, trauma's time to lose the ego. Let's put the most skilled person, the person with the most experience, right on top. Let them be the first person to intubate that patient. Sometimes you can be doing something else, whether it be a chest tube, tourniquet, reassessing the patient, doing a fast exam, and letting a paramedic or respiratory therapist do the intubation. For airway essentials, also need something to confirm placement. Easy capnometer, good thing. If you get really fancy, you can have inline capnometry or a capnometer monitor. That would be great too. Hemorrhage control. Sometimes that's the secretary holding pressure. That's completely fine. Tourniquets, easy, simple. They should be everywhere. Pressure dressings, pelvic binder. If you never put a pelvic binder on, you can even use a sheet. The thing I find with pelvic binders is that they're often placed too low. They'll drag down. Get it placed high, get that sucker on. The sheet works fine. You can have two people tie it like you would a square knot and just pull that sucker down. It actually works very good. It does a very good job. Blood readiness. How fast can we get blood? This is something you should know, something you should plan for. How much blood do we have? How much O negative blood do we have? How much O positive blood do we have maybe for an older patient? The O positive blood also be worked fine for males. What's our mass transfusion protocol? Is it the lab and a couple people warming up some fluids, warming up some blood and getting it ready to go? That's completely fine. Or do we have a fancier device? I wouldn't buy a fancy device if I'm not going to know how to use it. So it's something that we should be running drills on in our emergency department so people know how to use. Warming, blankets, forced air, bear huggers or such. Make sure you have something you can warm the fluid and the blood up in. Again, that might be a bucket of hot water. That's completely fine and appropriate. But there are some fancier, more expensive devices out there too. The fast exam, portable x-ray. Nobody should go to the x-ray department. You should be able to get that data right away. I think chest and pelvis is something now that we should get. The extremity x-rays, I don't even think they're that important. You can splint those things. You can put a tourniquet around those if you need to. But if you're not going to fix it, it's really not super important if the patient's really sick. You can get them out of there. If you've got time and the patient's not that sick, you clearly can do the extremity exam, look for pulses, something that needs to be splinted, something that needs to be quickly reduced so you can save that extremity. But you're trying to save lives in the golden hour. So let's focus on that first. Transfer readiness, clear trauma referral pathway. Where do we send our patients to? Where do we send our kids to? Where do we send our adults to? Who has neurosurgeries? What's the level 1? What's the level 2? You should have that readily available in your emergency department. I strongly recommend getting a binder that has our most regional resources. This doesn't include just trauma. It can be cardiac, it can be SANE exams, sexual assault exams. Who do we call for what? It's an excellent thing to have. Poison controls number. It should be readily, easily accessible, ready to go. I would also recommend a Broslo tape or similar. Pediatric patients, especially pediatric trauma patients, can be very challenging. You're nervous, the team is nervous, they don't know what to do. So having that Broslo tape, especially I like the one that has each color large, so that way I can take it, identify the color in a hurry, and really blow it up and see what do I need to give my patient, how do I give it fast. So good tool. Ultrasound guided IVs, good tool, probably not the emergency tool. I love the Easy IO. It's fast, it's easy, it's readily available. Ultrasound guided IVs takes a little bit of time. I think it's a great skill set to have, but it's not my go-to for trauma patients. So we also talked about call the EMS and helicopter early. Mobilize the troops. Your air ambulance companies will come without a diagnosis and an accepting doctor typically. They're here to help you, so know who your regional referral partners, know who your backup plan are. There are some sophisticated systems that I suspect will only get better that will show us who the closest helicopter is, how fast they can be to us. That's coming, and it's already in some of your facilities because I've seen it. But go ahead and call them, pick up that red phone or whoever it is that's closest to you, even call your local paramedics. I know many of us, especially in the community and rural settings, are still taking our patients to the local airport for EMS transport by helicopter. So we got to get these patients ready to go early. Call your EMS, let them know you need help. Sometimes it's nice to have the extra pair of hands. Sometimes they have some extra devices. Same thing with the helicopter. They oftentimes will have extra units of blood. Many of them now can transport with blood and specialized equipment. So go ahead and call them, get them there early. The rural trauma care is going to absolutely succeed when we prepare, we simplify, and we make an early transfer decision. Remember, every facility should have a code trauma. We should be ready to go. So I took a quick snapshot of kind of the southeast, not including South Florida. You can see here your level designated trauma centers. There's a decent void in many areas of our country. If you look here, there's lots of them around Atlanta. Obviously there's some in Macon. There's a large void along this I-16 corridor. There are some that are getting level 4 trauma designation. So that's coming. That's exciting. I think many of your facilities might get a trauma designation as well. It definitely helps with training, resources. But we have a lot of big voids. So know that these patients may come in by car, which is much more scary than come by ambulance. So we know they're coming. Know that we might have to do a decon situation. Then make sure that we protect both our staff and the patients from other people and future referral resources. So here's kind of what you would see for the level 1s, which are the reds. The level 2s are this kind of lighter orange color. So knowing your referral partners, knowing where to send them, knowing who does kids, knowing these for your area is very important. A couple of resources here. Of course, if you haven't, the crash trials were head injury and TXA, great trials. I strongly recommend looking up those. The American College of Surgeons, if you haven't taken ATLS, we're currently now in the 11th edition. So now that you've completed this course, you should be able to define what the golden hour is. Remember, the golden hour is not specifically 60 minutes. It's how can we do things faster in an organized plan to hemorrhage control, make sure we're protecting the airway, and we'll make sure we're decreasing that immediate mortality while also decreasing the future morbidity of our patients. Identify the latest ATLS updates. We know that ABGs, lactic acids are part of the algorithm now. Chest X-ray and pelvis are part of the algorithm now. The most important thing is identifying things that we can stop the bleeding now, stabilizing the patient, whether it be a chest tube or intubation or some sort of airway device, and defining where that patient needs definitive transfer. There's no need to do advanced imaging such as CAT scans and what have you before that patient gets transferred out. I'm so excited when I'm working in the level 1 trauma centers and someone calls me and says, I got a chest X-ray, I got a pelvis, I recognize this patient was sick. Sometimes I had a positive fast exam, and I decided it was time to get that patient out. I've already started blood. The helicopter's here, and they'll be at your emergency department in 20 minutes. That's fantastic. That's what we're looking for. That's how you save lives. That's the pathway between the most recent ATLS updates and the golden hour. Identify what resources you might need in your hospital. Develop that code trauma. Who do we need? Do we need respiratory therapy? Do our radiology team, do they need to have a pathway so we know what we need, how we can get it here faster, how we can get it here timely? Identify hemorrhage control algorithm. Stop the Bleed. Stop the Bleed is available. The Georgia Trauma Commission as well as other regional state trauma commissions are often doing grants for Stop the Bleed. You can get a tourniquet now for free. Put those in the civic centers. Put them in the church clubs, just like we did AEDs. I think this is fantastic. So identify hemorrhage control. Know you can leave this tourniquet on for a long time. There's no reason to take that tourniquet down and kind of look things over before the patient transfers out. We talked about the March protocol. One of the things I think is kind of cool about that is we're now putting airway second a little bit with our trauma patients. So yeah, we make sure they can breathe, make sure oxygen delivering, but we're preparing to intubate or preparing that supraglottic airway while we're controlling that massive bleeding and identifying the patients ready to be transferred. Sometimes when I'm working in the rural hospital setting and I get this sick patient, the first thing I do is ask the secretary, go ahead and call the helicopter, go ahead and get me a level 1 trauma center because I've identified this patient sick and I need to get them out. Then I can work on stabilizing the patient and getting them ready. I've never had a helicopter crew get mad at me or slap me on the hand saying, you shouldn't have called us when they don't transfer the patient or if the patient unfortunately is too acutely ill and doesn't make it. They would much rather be called early, mobilize the resources, get that blood ready, and be ready to go. This course is accredited for an hour of CME. The more information to follow on that. This is the quiz that is necessitated for that. So you can get that later, and we'll make sure that's available to you. This is an excellent opportunity to increase the level of your trauma care in your facilities, increase that trauma knowledge. We talked a little bit about our crystalloids, the oxygenation beats intubation, and getting that fast exam skill. I strongly recommend it. If you have any questions about this course, feel free to contact me. Here's my contact information, my cell, my email right here. I'm going to leave this slide here for a few minutes, but if you have any questions, feel free to reach out. You can also reach out to the Hometown Health online system at the email below should you have any trouble getting your CME, or if you want the slides of this presentation, we will make those readily available to you, as well as the resources therein. We're excited about as we deliver this trauma course to our rural and community hospitals, and really proud to be part of this. Thank you so much. Again, my name is Jay Williams, CMO of Southland MD. It's nice to see everyone. Have a great day.